Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is October 22nd, 2025. This video is on a New England Journal of Medicine article titled Hair Loss in Women by Dr. Elise Olson. What is the most common cause of hair loss in women? Female pattern hair loss is the most common cause, characterized by progressive thinning with central or frontal accentuation and preservation of the hairline. How prevalent is female pattern hair loss across age groups? It affects 3 to 12% of women in their 20s to 30s, 14 to 28% in their 50s, and up to 56% over 70 years old. What is the hallmark of clinical features? Central scalp thinning, variations in hair shaft diameter, preserved follicular openings, and no scalp inflammation. How is it different from male pattern hair loss? Unlike male pattern baldness, women typically retain their hairline and have diffuse thinning rather than complete baldness. Is female pattern hair loss always linked to high androgen levels? No, most affected women show no signs of androgen excess, despite partial androgen sensitivity of hair follicles. Which medications are FDA approved for this condition? Topical minoxidil 2% twice daily or 5% foam once daily, and are effective in over 50% of the women. Can oral minoxidil be used? Yes, low dose oral minoxidil less than 5 milligrams per day, off label, and may be as effective as topical minoxidil. Are anti-androgens effective? Agents like spironolactone, bicalutamide, flutamide show benefit but lack robust trial evidence. What are the non-drug treatment options? Microneedling, platelet-rich plasma, low-level light therapy, and fractional laser therapy offer adjunct benefits. What role does biopsy play in diagnosis? Scalp biopsy confirms diagnosis, assesses follicular density, and excludes other causes like cicatricial alopecia. What are the common side effects of oral minoxidil? Hypertrichosis, peripheral edema, transient shedding, and in rare cases, pericardial effusion. Is treatment safe for women of childbearing potential? Cautions advised with anti-androgens. Contraception is recommended during treatment. Can hair loss occur with aging alone? Yes, age-related thinning or senescent alopecia may be a part of the pattern hair loss or a separate entity. How is hyperandrogenism evaluated? Assess for hirsutism, irregular menses, acne, polycystic ovary syndrome, and measure androgen levels in blood tests. What diagnostic conditions must be ruled out? Differentials include telogen effluvium, frontal fibrosing alopecia, and central centrifugal cicatricial alopecia. What's the role of ketoconazole shampoo? It's an antifungal with anti-androgenic properties, sometimes prescribed adjunctively to minoxidil. How effective is platelet-rich plasma therapy? It can increase hair shaft diameter and density after about 3 sessions. Maintenance treatments are needed. What are the surgical options? Hair transplantation using follicular unit extraction is an option for select women with stable donor areas. Are there special considerations in breast cancer survivors? Use topical oral minoxidil. Avoid anti-androgens unless safety is established. Light therapy and microneedling are safe options. What are the knowledge gaps in this field? There's a need for better trials stratified by age, hormonal status, and genetics to tailor treatment. Eponyms in hair loss. The Christmas tree pattern of female pattern hair loss with widening central part and frontal thinning was described by Elise Olson, the author of this article. Ludwig, the Eric H. Ludwig scale classifies female hair loss severity into 3 grades of diffuse central thinning while preserving the frontal hairline. The Hamilton-Norwood classification, described by James Hamilton and Otto Norwood, originally for male pattern baldness, is sometimes applied to women exhibiting male pattern features. The Whiting ratio or the TV ratio, DA Whiting, demonstrated that a reduced terminal to vellus hair ratio, example 1.7 to 1 in scalp biopsies, is a key histologic marker of androgenetic hair loss. Clinical pearls. Topical minoxidil may initially increase shedding, and this indicates entry into anagen phase. Consider spironolactone greater than 100 mg per day for women with hirsutism and female pattern hair loss. Diffuse hair loss with positive hair pull test suggests telogen effluvium, not pattern loss. Scalp biopsy is essential when diagnosis is uncertain or cicatricial alopecia suspected. Microneedling enhances topical drug penetration and anagen induction. Diagnosis and therapy ladder. Central thinning with preserved hairline suggests female pattern hair loss. Global shedding and positive hair pull test consider telogen effluvium. Frontal recession with follicular loss and erythema suspect frontal fibrosing alopecia. Diagnostic tools: trichoscopy, scalp biopsy, serum androgens, thyroid and vitamin D and iron. Start with minoxidil and add anti-androgen if hyperandrogenic. Consider adjuncts like platelet-rich plasma, light therapy, and microneedling. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.